this morning. Discuss the surgical structural heart interventions, and this topic to discuss, I thought, how in the world am I going to talk about all these surgical structural heart interventions in an hour and a half? So what I'm going to focus on today is guidance-directed evaluation of a patient with a structural heart defect, when to refer that patient to surgery. So we're not going to go over all the different surgical procedures. I mean, that's a whole nother talk. I could probably talk for 4 hours on ICU care and postoperative management. So I think, most of our talks so far have been related to like the guidelines and how we're evaluating our patients. So we're sort of starting from the beginning here. Thank you. So closures. Okay, we're going to review the current guidelines for the management of structural heart disease and discuss the indications for surgical intervention. We'll have some time, hopefully, for Q&A, putting it all together, maybe talking about some patients that you guys have seen. After today's talk, my hope is that you will be able to evaluate the patient with a structural heart disease and then when to refer for surgery using evidence-based guidelines. We have used 2014 ACC/AHA guidelines for the management of our patients with structural heart disease. This year in March, we were at ACC. They actually presented quite a few updates to the guidelines, and so that is going to be included in this talk as well. So our new current guidelines, which were just released in March of this year. So the 2014 and 2017 updates and the links are included. We also look at SES guidelines and AATS. Those links are difficult to navigate unless you are a member or allied health member and have a login. So I didn't put those links up here, but are accessible like through our Prairie system. So when we're looking at recommendations, then we need to know the strength of the recommendations. So class 1 indications, we know it's strong, it's recommended. This is what we should do for every patient with these conditions. Class A, the evidence is good, it's moderate, it's reasonable, it can be useful. 2B is weaker, may be reasonable or considered. The effectiveness is either unknown or unclear. And this is when I think our team and interdisciplinary approach comes into play too, when we're getting out of those class 1 and 2A indications where we kind of come together and put our heads together to see what's best for the patient. 3 indications actually show no benefit. It's not recommended. It may also cause harm. So we do not want to do any class 3s. The review level is high quality from more than one randomized control trial or meta-analysis of high quality RCTs or high quality registry studies. B is randomized, and so that's moderate quality from one or more trials, meta-analysis, or moderate quality randomized control trials. Level B is non-randomized, and I use these abbreviations throughout the talk, so that's why I'm kind of going over these. Moderate quality evidence from one or more well-designed, non-randomized study or meta-analysis. Level C, limited data. So studies have limitations in their design or execution. It's not quite as strong of evidence. And then the EO, expert opinion, that's a consensus of experts based on their clinical experience. So disease can include congenital abnormalities. Basically, it's a defect or abnormality of the heart that is non-coronary and doesn't involve the blood vessels. So at our structural heart team, we're dealing with, the valves, any abnormalities of the chamber of the heart, things involving our coronary arteries. So, comprehensive list. I thought we would talk about some of the more common structural heart abnormalities that we see in our patients. Aortic aortic regurg, mitral stenosis, mitral regurg, and endocarditis. I was going to hypertrophic obstructive cardiomyopathy on there, and then I'm like, where do I stop? So this is what we're going to talk about today. We'll get to those other issues with our cardiomyopathies and future talks that we do. They stress the importance of articulate objective findings. So when we talk about patients with structural heart disease, and we talk about the stages of their valvular heart disease, I'll know like New York Heart Association class and CCC class of angina. But the stages of valvular heart disease, when we discuss these abnormalities, stage A are those patients who are at risk or have risk factors. So can you think of any patients that would be at risk for developing a structural heart disease, valvular disease? We're getting older, that's very good. Patients who are born with bicuspid valve, patients who have had rheumatic fever. Yeah, exactly. Would be stage A. B would be progressive disease. These are patients who have mild to moderate severity of their abnormality, but they're asymptomatic. So these patients that you know a defect of the valve structure, but they're not symptomatic yet. We're just following those patients. C are asymptomatic patients who have severe findings on diagnostic testing. They be compensated with the no change in the left or right ventricle pressure. So that's called C1, or asymptomatic patients who have severe disease with decompensation. So decreased left ventricular systolic function, severe diastolic dysfunction, heart failure. Those would be class C2. And C is the severe symptomatic patient. So we'll see those terms discussed. You can know A, B, C, and D and what they mean. At a patient has a structural heart abnormality, and we're talking about potentially performing surgical intervention. We're looking at the patient's surgical risk. And historically, we use the STS risk calculator. It's an easy online tool, plug, put in information, and it provides you with a predictive risk of operative mortality. I'll also give you a percent of risk for morbidity surrounding the procedure or long length of hospital stay. When we did, we would look at patients with regard to frailty and major organ system, but I think really when we thinking more in terms of low, intermediate, high, prohibitive is the advent of TAVR. And we all need to be on the same page as far as these patients' surgical risk, and we need a consensus. And how do we come to that consensus of how risky is this procedure for the patient? So look at the STS score. It can sometimes underestimate the patient's risk because it doesn't have all of the comorbidities. It doesn't count for everything. So we look at frailty, and that's a really important look at when you're looking at assessment of risk. Patients who are independent of their ADLs, patients who have strong grip strength, patients who can quickly walk 5 meters, less than 6 minutes, their gait speed, those patients are considered less frail. But if they have 1 or greater than 2 indices, it increases their risk for operative morbidity and mortality. Your organ system compromised, not to be improved postoperatively. So chronic liver disease, COPD, terrible obstructive lung disease with poor FEV1, FVC, those patients in spite of their aortic valve replacement are not going to get better. Now, if they have like hepatic congestion, and that's the factor that's a little bit different from heart failure that may get better with a structural heart intervention, but chronic cirrhosis or things like that, we are not going to be able to fix. And for specific impediments, so one for me is, let's say, a redo patient who has had coronaries 12 years ago, and now they're back because they had AS and they need an aortic valve replacement. We look at patient and their lima to LAD is wide open. It's a beautiful wide open graft. And they're pretty dependent on that graft because maybe a couple of their other grafts are down or they're blocked a little bit. And so now we're going to think about going through a sternotomy again. And CAT scan, we see that lima crosses the midline. And so upon reentry to the chest, there's a high probability that we would compromise that lima graft. That would bump that patient up into higher prohibitive risk for redo operation. Cannot be evaluated on a plug-in chug risk layer like STS or Euro score. So these for surgical structural heart intervention are median sternotomy, also mini valve procedures. Durako, our partner surgeon, has been a pioneer in bringing a mini program to Springfield, which is really great. They use anterior thoracotomy incisions for replacement of aortic and mitral valves. You can do a mini midline sternotomy, and there's all kinds of different ways to do that. You swing the ribs over. Then, of course, we have our percutaneous and catheter interventions, which we are currently involved in aortic valve replacement and then the mitral valve repair procedures. So if the patient is going to be a candidate for a surgical structural heart intervention or percutaneous or maybe medical management or perhaps palliative care, we have interdisciplinary structural heart team collaboration. And exciting things about the TAVR program is that it really brought to light the importance of a team approach to evaluating these high-risk sick patients. If you had a chance to go to one of the meetings and see what they talk about and how they work together to walk through these patients that are so difficult to manage, it's incredible. So I think that's like one of the most awesome things about our program is that we have this interdisciplinary collaboration. And it's sometimes to make a choice for these patients. So now a few of the individual structural heart abnormalities. Aortic, this is, pretty much a review. There's thickening and calcification and or fusion of the valve leaflets. So if you have a younger patient who has aortic stenosis, typically they have a congenital bicuspid valve, either a true bicuspid, two-leaflet aortic valve, or sometimes failure of the commissure to split, and so there's a fusion of the leaflet. So they've got a functional bicuspid valve, is what we call it. Older patients is typically a degeneration of the changes in their tri-leaflet valve, and it's a senile calcification. Most of us, long enough, will have some degree of aortic valve stenosis. Pathophysiology for aortic stenosis, there's impairment to cusp opening, there's pressure overload in the left ventricle. So there's left ventricular hypertrophy and in turn reduced ventricular compliance. So this is our body's compensatory mechanism trying to overcome this impairment to the cusp opening and outflow. Ventricular hypertrophy does a good job because it maintains normal wall stress and a normal ejection fraction in spite of the decreased flow across the valve or across the valve. So until the pressure in the left ventricle overcomes that hypertrophied muscle, and then the EF begins to fall. And that's when it becomes symptomatic. So ejection fraction can be due to either excessive afterload or contractility. So excessive afterload would be due to the tidal calcified valve or the depressed contractility, the inability of the ventricle to appropriately contract. So would hold a higher surgical risk a patient who has either a really stenosis aortic and high afterload or depressed contractility. Patients have high surgical risk because their ventricle cannot contract appropriately, and even when we change them to a knee, they're still going to have depressed contractility, and so they have higher surgical risk. On the side, patients can have excessive or inappropriate ventricular hypertrophy with hyperdynamic, and those patients are at high risk as well because that in the absence of the afterload will contract so on itself, it can actually obstruct the left ventricular outflow tract. It can cause systolic anterior motion of the mitral valve into the left ventricle, which causes severe MR, which is set up for cardiogenic shock. PAS becomes symptomatic. It's a mechanical problem, and if it's not fixed, they'll develop symptoms. If it becomes severe, enough, and the angina. And why do patients with AS get angina? Yep, there's increased myocardial oxygen demand, increased wall stress. There's reduction in blood supply. Hypertrophy hearts are more sensitive to ischemic injuries, so they get pain. They get failure because elevated filling pressure, so that left ventricular end diastolic pressure increases. There's dysfunction, so that heart can't stretch and fill. You know, that remember the stretch and fill, the Starling's law with the band. If you can't stretch, you can't squeeze. So there's diastolic dysfunction and progressive decline in that left ventricular systolic function. And why? Cardiac fixed across that aortic valve because the very hard to keep our cardiac output the same in the setting of a severely stenosed aortic valve. But it's very sensitive to decreased preload. So peripheral vasodilatation, if you're trucking along just fine with your AS and then you go into AFib and you lose that atrial kick and that preload into your ventricle, you cannot compensate for that. So then patients pass out. So diagnosed aortic stenosis, and I'm not going to go over the different, you'll know what an echo and cardiac cath and a Dubini stress echo is, but we know that the echo allows us to calculate the valve area, the gradient across the valve, the velocity across the valve of blood flow, cardiac catheterization. You can use a pressure wire across the valve and measure the gradient in the ventricle, and then aortic valve, so we can check that. You don't know cross the aortic valve if it's a severely stenosed type aortic valve. Of course, that could potentially, for a diagnostic cath, not necessarily TAVR where you have to, but that puts patients at risk for embolization and stroke. And in evaluating these patients, coronary angiography is in as well, because if you're going to be doing surgery for an aortic valve, you need to assess their coronary risk. And that class 1 indication that angiography is indicated before valve intervention for patients, and this is, if you think about it, it's pretty much everybody. Patients with angina, if any objective evidence of ischemia, if they have a decreased EF, a history of AD, or any coronary risk factors, so include men over age 40 or postmenopausal women. So these patients get a cardiac cath. Even if they've had any coronary history, just their aortic valve stenosis, we check a diagnostic cath on all of them. Stress echo. This is an important player because across the valve has to do with the size of the valve orifice and flow across the valve. So in some instances, the ventricle can't produce enough stroke volume to be able to appreciate the degree of aortic stenosis. So we use an inotrope, we use dobutamine, to increase that stroke volume and the cardiac output. So we do that, and there's little increase in the gradient. So an appropriate increase in stroke volume and cardiac output, but the gradient doesn't increase to meet that 40 millimeters mercury mean or 4 meters per second velocity, then we've overestimated our degree of AS, and the patient doesn't really have severe aortic stenosis, and they, we continue to monitor them. Intervention would not be indicated. If doing stress echo increases the stroke volume and the cardiac output, and then there is an increase in the gradient, then we underestimated the degree of stenosis because we have low flow, low gradient, and then those patients, surgery is indicated. Ask Jenny for help on this. If stress echo fails to increase the cardiac output and their stroke volume, is it 20%? Is that the cutoff? Okay. Yeah. So if their EF doesn't increase 20%, then what? Then you. Okay. Got it. Okay. Perfect. So, and those patients probably have poor contractility. They would be high interventional, surgical or percutaneous risk. So, okay. How do we find severe aortic stenosis? So criteria, for peak velocity across the valve of 4 meters per second, a median of 40 millimeters mercury, area of less than 1 centimeter squared, or dimensionless index of less than 0.25. And for the longest time, I heard this dimensionless index, and I'm like, what does that mean? I didn't know. You know, for the longest time, I didn't know. So, dimensionless index is a velocity ratio. And so they use this velocity ratio in the assessment of the valve dysfunction when it's difficult to measure the LV outflow tract diameter or the valve orifice. So it takes out of the equation like valve size and the conditions producing the flow. The ratio is not altered by those conditions. So it's more of an objective number, I guess. Is that patient prosthesis mismatch patient, the morbidly obese patient that has a normalized aortic valve, but they just get, I mean, it's just not enough cardiac output for their size. Okay. It takes body surface area, and it's a pretty long equation, so I didn't put that on there. I didn't figure anybody would want to calculate. But it's always on your echo, and they always talk about it in the meeting. They include that dimensionless index. So it's a like biased number, maybe, would you put it, or? Got it. Okay. Mm-hmm. Okay. You just have to have one of these things. Yeah. Two.
I can never remember some of these numbers. Obviously, I can remember boundary less than 1.
4 and 40.
But some of these, you know, velocities and things like that. So I always put Echopedia on my phone.
Yes.
I don't know if you guys know about that. It's easy.
Mm-hmm.
Yeah, so.
It's wonderful. Uh-huh. I understand what that measurement. I know they're looking at post recovery. Because sometimes you'll have some high flow and high velocity after the procedure as a recovery compensation. And the acceleration takes that into account. So I can tell you right now, without fully understanding the whole reason behind it, what that people want. If it's over 100, then it could over 100, then that could mean that there is residual stenosis. Yeah. Okay. So the thing is, like, so if you see a post-cath patient and their velocity is like 3.9 or something like, holy cow, that's pretty bad. But they'll calculate the acceleration, and that's terrifying. Well, then they're looking too if it's a hypertrophied hyperdynamic ventricle and there's increased flow, in stroke volume or speed of volume. That makes sense. Exactly. And we know that probably won't get better as the metals, and there's less. Okay. Very good. Clinical pearls with each of these different scenarios. Just we need to remember that working up the patient with AS, we should never perform exercise stress testing in patients with stenosis when the velocity is greater than 4 meters per second or the gradient is greater than 40. They are at risk for sudden cardiac death. So it's class 3 harm. For surgery for patients with aortic stenosis are severe aortic stenosis criteria plus symptoms. So those are stage D patients. Aortic stenosis, if they're asymptomatic and their EF is less than 50. So remember, C2 is comprised of the right ventricle. So they're symptomatic, they have severe criteria, and now their ventricle is failing. So it's a class 1 indication for surgery. And then severe AS, either stage C or D, who are undergoing cardiac surgery for other indications, cabbage or, you know, whatever. I have the low EF regardless, because it's unless they have known ischemia or, you know, they've had a prior, I don't know how they would tease out what was what. So it's symptomatic. I believe that they would still be C2 because their EF is low. It's compromised for whatever reason. Yeah, and I put these algorithms in here. They're hard to, you can't read them really on the screen if you have the PowerPoint slides. From ACC, they do an excellent job of outlining the criteria and then the class of indication. So I'm just going to, you know, talk about the class 1. There's the class 2A and 2B indications for AVR. I'm not going to like put you guys to sleep with all of that, but if you have a patient who has yes, you can follow this algorithm and just, you know, when they would be referred for consideration for surgery. Because there was concern that with the of TAVR that there would be less aortic valve, you know, surgical aortic valve. That's not really the case. Like our numbers are good and actually going up in some areas because I think that the recognition of aortic stenosis, severe asymptomatic aortic stenosis, is kind of in the front of everybody's mind now. It used to be, well, your velocities are high, but you're not symptomatic, and your EF's okay, so we're going to keep kind of watching it. But the problem with that is that patients who develop severe aortic stenosis, actually their long-term survival is not good once they meet the severe standpoint, and then they start to have symptoms. Once symptoms onset, that survival is about 2 years, with less than 20% survival at 5 years. So if you have symptomatic aortic stenosis and your symptom is congestive heart failure, your average survival is 1 year. If you have syncope, it's 2 years, and if you have angina, it's 4 years. So, you know, we're reaching these patients sooner. We're keeping a closer eye on them. So, you know, IVR is going to go to the side, you know, hopefully time soon, but we're paying more attention to these patients, which is good. Some 17 updates, which we talked about at the ACC, were that, and I think Jenny went over these too because they involve TAVR, but the recommendation for either surgical AVR or transcatheter AVR among high-risk patients, severe symptomatic AS, are stage D patients after consideration by the heart valve team was changed from a 2A level of evidence B to a class 1A level of evidence A indication. So that's the strongest level of indication that we can provide. And TAVR is also a reasonable alternative to SAVR for stage D aortic stenosis in the intermediate surgical risk. So the patients that aren't higher prohibitive, immediate risk patients, is a class 2A level of evidence B randomized. And now we're enrolling in our low risk partner trial, which is important to know how they're, if they are low surgical risk and choose to have transcatheter aortic valve. So if you have a patient that has AS and it's severe and they're a low surgical risk, you know, we want to know about those patients and try to get them enrolled in partner. Right. Trump's correct. Other asymptomatic, yeah. So exciting stuff, and we're very privileged to be a part of that. Our small, you know, Midwestern community that we get to see all this and kind of be on the forefront. Regurgitation, so we're going to move on from the stenosis to the opposite problem, regurgitation, or you'll see AI, aortic insufficiency. The guidelines refer to it as regurgitation. I don't know, my dog is AI, so whatever. It's, you know, tomato, tomato, but it's an abnormality in the aortic valve leaflets, either caused by calcific degeneration, that bicuspid valve, endocarditis, or something that dilates the aortic root that prevents leaflet coaptation. So aortic dissection, blunt chest trauma, and also be iatrogenic following balloon aortic valvuloplasty or transcatheter aortic valve procedure. Aortic insufficiency usually results from endocarditis or a type A aortic dissection. or carditis again. I don't know why it's on her twice. So those two things are the most common causes for acute AI. When patients develop acute AI, there's this sudden increase in regurgitant volume into that left ventricle. And so there's increase in the left ventricular end diastolic volume and pressure. And the ventricle hasn't had time to compensate for that. This is just an acute event. The ventricle is just trucking along, and then all of a sudden there's all this regurgitant volume. So develop acute left ventricular failure. This leads to cardiogenic shock, pulmonary edema. These are high-risk patients for mortality. There's increase in the afterload, and this causes myocardial ischemia, tachycardia, and sudden death. As left ventricular end diastolic pressure approach aortic diastolic pressure, so the aorta is relaxing, the ventricle is stretched as pressure is, then there's really decreased coronary perfusion because the coronary is filling diastole. So you have profound coronary ischemia, and urgent surgery is recommended for these patients with severe acute AR from either of these problems, because otherwise they won't survive. They won't survive, you know, trying to tune them up or whatever. They don't have time for that. So you got to get them to the OR. Chronic is different. This is pressure and volume overload in the left ventricle and progressive LV dilatation. So this is happening slowly over time. There's increased wall stress, increased compliance, but the ventricle can deal with that. It has progressive hypertrophy. It has time to think about it and like get back to normal. So patients can be asymptomatic for years due to this compensatory hypertrophy and their preload reserve. So if EF stays normal, they don't feel bad. They make pulse pressure and bounding peripheral pulses on physical exam. Aortic insufficiency or regurgitation are dyspnea and angina. So the left ventricular systolic dysfunction causes a fall in the EF, which increases the pressure in the heart and causes increased pressure in the pulmonary veins, which causes pulmonary edema. And impairment of the coronary flow from that diastolic dysfunction causes angina. So these pain, and they'll be short of breath. And that's like a common thread with most of these valvular problems, right? I have chest pain, I feel short of breath. So once we diagnose aortic regurgitation with echo, and then aortic root aortography at the time of cardiac cath. So when they do a root shot and they inject the dye and then they see it wish-washing back into the ventricle, that's a pretty good visual of that severe aortic regurgitation. Criteria for diagnosis of severe aortic regurgitation is the dilated left ventricle, abnormal leaflets or wide coaptation defect, so a dilatation of the annulus and a coaptation defect. Doppler, there's a central jet width of greater than 65% of the left ventricular outflow tract. So when you see that regurgitant volume is taking up 65% of the VOT, it is a criteria. The Doppler vena contracta, again, I'll look that up because I wasn't sure about the vena contracta. That's the narrowest central flow region of the jet that occurs at or downstream to the orifice of the valve. So you want to see a width greater than 6 millimeters, a wide central jet, essentially, is all that means. I mean, that's like a fancy way of saying that. And then the regurgitant volume is greater than 60 mils per beat. That's a lot. You know, milliliters every heartbeat, 60 mils regurgitant back into that ventricle, and then the fraction over 50% and the orifice area or coap defect of greater than 0.3 centimeters squared, greater than or equal to. The average, right? I don't know. Normal. Yeah. It is. That's a lot. Most of the LV volume, right? Idea of that, and it probably depends on the ventricular size too. It's probably dependent, but like a normal, yeah, that's a really good question. media that so we can get it on the recording. And she's on. Okay, take your time, take your time. Okay, so clinical pearl, I'm trying to throw these in there. I'm hoping you guys aren't falling asleep with all this. So we have intra-aortic balloon pump in a patient with severe aortic regurgitation. Right. Of the diastolic blood pressure during the counter pulsation will worsen that regurgitant volume. Judicious use of beta blockers. Why? They do bradycardia, right. So we use beta blockers in acute aortic dissection, so like esmolol drip aortic dissection, because beta blocker decreases the change in pressure over change in time, so that shear force on the aorta, which is important if you have a dissection flap, right? You don't want that gangbuster, cardiac output that's going to shear that dissection even worse. In all other patients, then the tachycardia, the compensatory tachycardia, helps keep their cardiac output up. So if you slow their heart rate, they're going to fare worse.
So it says LV systolic volume in milliliters.
Yes.
With range 19 to 49, mildly abnormal 50 to 69. Really?
And diastolic volume, when the ventricle is full.
Diastolic volume. Okay, here we got it. Reference range 56 to 104.
So
60 is still a lot.
It's a lot. That's almost your entire, half or all of your LV volume is coming back. Yeah. So that makes sense of why why they feel so bad. Last one, indications for surgery for these patients are symptomatic stage D with severe regurgitation regardless of their LV systolic function. So that's the level of evidence. Asymptomatic patients with chronic severe regurgitation and a depressed left ventricle. So there's our C2, we've got a non-compliant ventricle, and if no other cause for LV systolic dysfunction. So that level of evidence B, so that is where you have to look into an ischemic cause of LV systolic dysfunction for them to meet that criteria for aortic regurgitation. It didn't specify that for stenosis though, so that's interesting. Severe AR, C or while undergoing other cardiac surgery. So again, while they're in there, if they're severe, it would be fixed. Algorithm, which delays class 1, 2A, 2B, and then when do we periodically monitor these patients? Moving on, mitral valve, pathophysiology of MS. So that occurs nearly exclusively as a consequence of rheumatic fever. We just had a 29-year-old patient who had rheumatic valvular disease and had a double valve. I have not seen a young person with rheumatic valve degeneration, I don't know if maybe we do that often. No, there's more out there. When I was doing some more reading up on this, there's an increased incidence of rheumatic valve disease. And so they talk about if there's any question or concern, these patients should be treated pretty aggressively with antibiotics. Or felt to have. And I don't know if it has something to do with, the lack of antibiotic administration, for we're out. That, but it probably has to do with the the leadership and how we're just not treating things like often as we do. Like aortic to senile calcific disease, greatly changes the course of treatment. We're going to talk mostly about MS related to rheumatic fever. There's thickening of the valve leaflets with commissure fusion, and then thickening and shortening of the chordae tendineae, and this causes stenosis of that valve orifice. So I put on here the indications for interventions in patients with senile calcific stenosis differ from rheumatic for the following reasons. The patient involves the annulus and the base of the leaflets without commissural fusion. So there's no role for percutaneous mitral or commissurotomy. So you can't just pop open those mitral valve leaflets. leaflets because it involves the entire apparatus. It's not just the leaflets. The process of severe annular calcification can be very challenging from a surgical perspective to try to get there and debride all of that calcification and then be left with an appropriate size annulus to replace a valve, to securely attach a prosthetic valve. And most of these patients are very elderly and debilitated, have multiple comorbidities, and high risk for surgical intervention anyway. So it causes a reduction in the size of the orifice. There's reduction in the efficiency of LV filling, and so this happens. Mitral gradient causes increased left atrial and pulmonary venous pressures, which lead to heart failure. This is complicated by decreased pulmonary microvascular permeability. So pulmonary arterioles vasoconstrict, they thicken, and these patients get pulmonary hypertension. Pulmonary hypertension leads to right-sided heart failure and functional TR from the increased pressures. So there's increased pressure across the pulmonary system, the artery dilates, and then you have a functional dilated tricuspid annulus and tricuspid regurg. So a lot of times, patients, if you fix their mitral stenosis, their regurgitation will improve as that ventricle can remodel, or they'll ring the tricuspid valve while they're in there, just to reapproximate that annulus to its normal shape. So, you know, again, backwards through the heart of how the tricuspid valve becomes an MS. You have a slow progression of symptoms. It's not an acute onset. The many symptomatic patient has an 80% 10-year survival. That's pretty good. Significant symptoms, there's less than 15% 10-year survival. So kind of if you're symptomatic, you should be treated and followed closely. Patients with severe pulmonary hypertension, so the pulmonary arterial systolic pressure of greater than 60, that's pretty darn high. Less than 3-year survival rate, and that makes sense. And then these patients will have symptoms of heart failure, New York Heart Association class 2 to 4 symptoms. Durako, again, it assesses the severity, determines the morphology, if valvuloplasty is possible, and then they also assess for cardiac thrombus. So it's important. These patients have restricted flow from the LA to the LV, and so they can morally form cardiac thrombus and cardiac catheterization to assess coronaries. Severe MS, mean gradient greater than 10 millimeters mercury, PA systolic pressure greater than 50, mitral valve area less than 1.5 centimeters squared. Anticoagulation with a vitamin K antagonist, Coumadin, warfarin, or heparin is indicated in patients who have MS and AFib if it's paroxysmal, persistent, or permanent. And then any I have the 2000 guideline, and it's applied, but I do believe discuss the direct oral anticoagulant role in these patients. Patients who have had operative intervention, but they have known MS, that there is a class of indication for the NOACs, the direct oral anticoagulants, in addition to the VKA. So there's another slide about that a little bit later. They changed that, so that's a new 17 guideline. MS and atrial fibrillation, said that, paroxysmal, persistent, permanent, MS and a prior embolic event, or MS and a left atrial thrombus, and these are class 1 recommendations. So, recommendations for intervention, percutaneous commissurotomy is recommended for patients who have severe MS, stage D, and favorable morphology, okay, as long as they don't have a thrombus or moderate or severe MR, so no regurgitation. Surgery is indicated for the class 3, 4, should be 4, not 6, NYA. Symptomatic. Those patients are really symptomatic. They're dead. Yeah, those patients are dead. So the surgery is indicated before they die. Symptomatic patients with severe MS who are not high risk for surgery and who are not a candidate or who have failed you know, this is very wordy, surgery indicated for patients with severe MS, stage C or D, who are undergoing other cardiac procedures. So again, you know, also in assessing our coronary patients, we're checking an echo, we're doing a good physical exam to make sure that there are not any additional structural heart defects in addition to their coronary disease. So rheumatic mitral stenosis algorithm by Journal of American Cardiology. And
I have a mitral stenosis question. I wanted to see, I'm very familiar with it, honestly. When we had a young lady, and I think it's the one you were talking about, I thought she was a little older than that, and she had valvuloplasty, a balloon valvuloplasty. And I didn't know that last, because in aortic stenosis,
not
it
long.
doesn't last long, but apparently her prognosis
Was good.
I don't know how long.
And I wonder if it's because since it's a lower flow system, I don't know. Do you know? Do you guys do? Amateurs are few. Just now.
Good. They didn't have a prognosis in the chart, and I meant to ask if Danny remember who did.
That's a good question.
So it would last quite some time, as opposed to an aortic valvuloplasty, which we all know is.
It's a temporary thing. Right. Just see. Another really good question too. So we'll look at duration of the
Can you do it again?
right, of mitral valve.
I think she was maybe in her 40s.
Well, we're able to repair. Able to repair the valve by commissurotomy, or even if it's this instance of regurgitation, you can do a durable repair if they have like a Barlow valve or a redundant valve from mitral valve or rheumatic valve disease. When you're not replacing the valve, you're leaving that subvalvular apparatus intact, and so the ventricle, when it squeezes, what happens muscles are and the chordates, and it's like a ring, it rings it out, so you keep that native function of the ventricle and the valve. And when you have replacement, they have chordal sparing operations and things, but for a younger person with a good repair, it's really, that's better because it maintains that normal physiology in the ventricle. But I didn't put any pictures on here. I'm lame. Google Barlow's valve. So it's a big lump redundant valve. So the leaflets are boggy and bubbled. Yeah. There we go. The Barlow valve. So can you see the just redundant, folded, lumpy, bumpy valve? Yeah, it reminds me of like a Shar-Pei, just like a wrinkly dog. It's a wrinkly, lumpy, bumpy valve. So sometimes, the leaflet only involved repaired. Okay, yes. In MR. It's in the coronary disease. Yes. Help with IT, guys. Okay. So, talk about now regurgitation. So that's a good segue into regurgitation, the Barlow valve. Due to an abnormality of the annulus, so dilatation of the annulus, which impairs coaptation of the leaflets, or valve leaflet dysfunction. So myxomatous change, redundancy, prolapse, a leaflet defect from damage from endocarditis, so a torn leaflet, or leaflet shrinkage. So no, Barlow's myxomatous causes the shrinkage. I misspoke. Chordae tendineae can rupture or elongate, and that happens a lot in the case of ischemic MR, and also papillary muscle rupture from ischemic dysfunction. So, excuse me, regurgitation of the mitral valve typically results from myocardial ischemia or infarction with papillary muscle rupture. It can be from endocarditis or also from idiopathic cord rupture. You can just pop a cord. This acute left ventricular volume overload from the regurgitant volume, the reduction in forward flow into this small, non-compliant left atrium. So our left atrium is not used to that regurgitant flow, and this causes pulmonary edema and cardiogenic shock. Chronic is progressive. So it's a chronic condition of volume overload. This progressive increase in the compliance of the left atrium, that stretching of the left atrium and ventricle, causes a progressive increase in the increased left ventricular end diastolic volume. There's increased preload with a small stroke volume. So sorry, back to the presentation. I'm like, oh, there's Kate. Okay. There's increased preload with small stroke volume to maintain the cardiac output, okay? And this decrease in the afterload due to the ventricular unloading into the left atrium. So the left ventricle is squeezing, and even, let's say, the setting of some aortic stenosis or increased afterload because of hypertension. If you have severe MR, it's like a pop-off valve. So the ventricle doesn't have to work that hard because there's that regurgitant volume back up unloaded into the left atrium. Normal ejection fraction can be maintained in spite of the contractile dysfunction. The volume overload, though, causes increased dysfunction and contraction. There's progressive left ventricular dilatation and increased end diastolic volume. So our normal 60 to 100 that we know causes elevated filling pressures, right? So the end diastolic volume is increased. That increases the atrial pressure, increases the pulmonary venous pressure, pulmonary heart failure, worse heart failure. Ischemic MR can be acute or chronic. Chronic ischemia develops after myocardial infarction due to ongoing ischemia. Annular dilatation prevents the leaflet coaptation, and then the papillary muscle displacement from left ventricular remodeling can cause tethering of the leaflet. So after a big MI, scarring or decreased or abnormal contraction of that left ventricle can scar down and cause tethering of the mitral valve leaflets. So ischemic MR has a worse prognosis. You hear versus secondary MR, especially in the setting now of talking about potential for percutaneous mitral valve interventions like MitraClip. So primary MR is degenerative MR. Of one component of the valve causes incompetence. So mitral valve prolapse. There's RLOs, big, boggy, redundant valve. There's chordal rupture. That's primary degenerative MR. Secondary or functional MR is caused because there's left ventricular dysfunction from whatever, CAD, MI, idiopathic myocardial disease. It is that abnormal dilated left ventricle. The papillary muscles are displaced, the leaflets are tethered, there's annular dilatation, and the leaflets cannot coapt. So there's not a problem necessarily with the valve leaflet, it's a function of what else is happening in the ventricle. And so when we talk about the structural heart clinic mitral regurg patients, we want to talk MitraClip for primary MR. Cannot, for to have functional MR, MitraClip is not indicated. It can't help. You want to tether those boggy leaflets. You do anything about that dilated annulus or those, chordae tendineae. Echocardiogram, TEE is the gold standard for evaluating the MR and planning surgery. It gives you the best visual. Ventriculography on coronary angiography can be used to assess the function and degree of MR. Regurgitation. the effective regurgitant orifice area of greater than 0.4 centimeters squared. And these guidelines, again, they're all listed on ACC. So and let's look at it all the time. You're not going to remember all of these things. But the regurgitant volume greater than 60 or regurgitant fraction greater than 50%, greater than or equal to 50%. Some clinical patients with acute MR, especially acute ischemic MR, are susceptible to pulmonary edema and multi-system organ failure due to their decreased cardiac output. So, in just specifically of a patient who came in with a huge inferior an anti and had wide open MR and came in pulmonary edema, liver failure, renal failure. These people, they're sick. They're just really, really sick. And so there's discussion between cardiac and surgery of what's the best timing for surgery for these patients, because when you go to surgery in the setting of multi-system organ failure and acute pulmonary edema, your operative mortality approaches 100%, and you temporize the patient with new technology such as MitraClip. If you have a flail leaflet, can you capture that leaflet and reduce the MR to moderate for a couple of days to allow their liver, their kidneys, or their lungs to recover, and then go on with surgery. So as we advance with our percutaneous technology and our multidisciplinary team, I think we're going to be able to treat these really sick patients more effectively because we'll all kind of work together. So, last one, indications for surgery. Surgery recommended for symptomatic patients with chronic severe primary MR. So that mitral regurg caused by a defect in something in the valve apparatus. So stage D, those are those symptomatic patients when their left ventricular ejection fraction is greater than 30%. What if fraction is less than 30%? Those patients for surgery, for open surgical procedure, right? Because if their LVEF is 20 with severe MR, once we fix that, because that and allowing blood in that ventricle is a pop valve for that systolic function. So if we fix that, it's going to look worse. It's worse. It looks a little better with severe MR. So the EF looks better in the setting of severe MR. It's recommended for asymptomatic patients with chronic severe primary MR and left ventricular dysfunction, 30 to 60%, or an end systolic dysfunction, left ventricular end diastolic diameter of greater than 40 millimeters, so dilated LV. This is stage C2, so that compensated ventricle, so the ventricle that's starting to decompensate, and that's level of evidence B. And repairs recommended in preference to replacement. Surgery is indicated for chronic severe primary MR limited to the posterior leaflet. So you can get a good durable repair, preference to replacement, so that you can maintain that subvalvular apparatus, so that when the ventricle squeezes, the chordae and the brain muscles are working to wring out that ventricle. So it works together to help with that ventricle's normal shape and function. If the MR involves the anterior leaflet and or both leaflets, when a successful and durable repair can be accomplished. So a lot of times you'll see mitral valve repair, possible replacement. Well, it's sometimes hard, we get good view on TEE, but it's sometimes hard to appreciate exactly how bad those leaflets are if they are able to be repaired. So the surgeon may attempt to repair knowing that we can, maintain that subvalvular apparatus. But if not, if you can't get a successful durable repair, if there's any leak, then you would go on to replacement. So replacement is indicated if the patient has chronic severe primary MR and they're having cardiac surgery for other indications. It's like a broken record. So if you're injured for something else and you have a valvular problem, we'll probably fix it. Indications, and there's a class B, 2B for repair, for surgery, and periodic monitoring. And those will be on the slide deck. So 2017 guideline updates from ECC in March when we were there. Among asymptomatic patients with severe primary MR with preserved LV systolic function and an E greater than 60%, and left ventricular and diastolic or in systolic dimensions less than 40, so that non-damaged ventricle, that's our C1 patients. Surgery is reasonable in the sense of serial imaging studies that reveal a progressive increase in the LV size or decrease in the EF. So you don't have to wait until their EF is less than 60% or their end systolic dimension is greater than 40 millimeters mercury. If you're seeing a trend toward that, then it's reasonable to operate on these people. The definition of severe secondary MR, so remember that's the dilated the same as for primary MR. So that's the criteria: effective or area less than 0.4, regurgitant volume greater than 60, and fraction greater than or equal to 50%. Honestly, off the top of my head, I don't recall what the prior criteria for secondary MR were, but I feel like it's nice that they're the same now. So now we don't have to remember two criteria. It's reasonable to choose the chordal sparing replacement or a reduction annuloplasty repair for patients with severe symptomatic secondary MR. So that is a change in the thought. Different if you repair a durable lapsed valve or redundant valve, perfect. But to have secondary MR or that dilated annulus, the surgical mindset and the guideline prior, that repair was always better than replacement because of that same reason, to preserve subvalvular apparatus. But now they have said, which there's been a trend in expert opinion and discussion, that it is able to choose the chordal sparing, so you leave the cords but you replace the mitral valve as opposed to just ringing that mitral valve. That's actually a more durable operation for a patient because they were finding that those repairs with the ring annuloplasty were not long-term durable. Patients were coming back with MR again because the ring repair failed. So that's those are stage D symptomatic patients, New York Heart Association class 3 and 4 symptoms. And that's a 2A, and that's randomized trial data. So that's good. That's good data. So we're changing our practice in that aspect. After a randomized trial showed no clinical benefit of repair among patients with chronic moderate ischemic MR undergoing surgery, they just changed the level of class from a consensus to randomized. So in looking at all of these patients, they've just stripped their recommendation. Let's see. Another little topic on repair of the mitral valve. So it has a lower operative mortality rate, and the left ventricular function is better preserved because it maintains the subvalvular apparatus. Also, you have to think it does commit the patient with a prosthetic valve to, if they're a young patient, mechanical valve to lifelong anticoagulation. There's a risk of bleeding, and there's a small risk of endocarditis with prosthetic valves, mechanical or bioprosthetic, of like 1% per year. So those patients do have a risk for endocarditis. I think the slide's out of order, so I don't know what's next. The next, though, is endocarditis. And so diagnosis of endocarditis, we will use the Duke criteria, so major criteria, minor criteria. You guys are probably familiar with those. Positive blood cultures, evidence on echo, or other predisposing conditions, fever, embolar vascular signs, or those Osler's nodes, Roth spots, splinter hemorrhages, a still positive blood culture, and then echo signs that are abnormal but maybe don't meet the major criteria. Obstruction of the valve leaflets. It invades the myocardial tissue. There can be systemic embolization of the valve vegetations and persistent systemic sepsis. So patients who don't clear their carditis have a persistent sepsis syndrome. Clinical as far as the pathophysiology of the structural heart problem, embolization is more likely to occur with mitral valve than aortic valve. So when you're evaluating a patient who you're concerned with endocarditis, if they have septic emboli, more likely from their mitral valve than the aortic valve. It's usually staphylococcal organisms and from large mobile vegetations, which that makes sense. Native valve endocarditis commonly are caused by strep viridans, staph aureus, or coagulase negative staph. Endocarditis is caused by IV drug abuse. We brought some notes from the ACC meeting, they were discussing guidelines for effective endocarditis, and the level of evidence if this is general consensus, but the speaker was discussing the fact that with tricuspid valve endocarditis, medical therapy, antibiotics, the patient would have recurrent bacteria due to the IV drug abuse. So these people, if you can care or treat medically, they're likely to return their IV drug abuse. So a replaced prosthetic has a higher incidence of endocarditis. So if you can keep them with the valve that they had, they're better off. Incidence of prosthetic valve endocarditis is about 0.5 to 1% per patient year for most prosthetic valves, mechanical bioprosthetic. Again, that leads to, that if you can get a good durable repair in the set of endocarditis, that reduces the risk for patients for having endocarditis. And then the most common prosthetic valve organism is staphylococcal. So this is just an algorithm that kind of goes through diagnosis of patients with suspected native valve or prosthetic valve endocarditis. And again, bore you with reading you all these slides. Duke criteria, you're going to check blood cultures, you're going to check an echo, and then either send the patient for early surgery, removal of some hardware, just depending on where they fall in the algorithm. So the 2017 guideline updates regarding endocarditis, and these are from the recent ACC AHA update. Operation without delay can be considered in patients with infective endocarditis and an indication for surgery who have suffered a stroke, but no evidence of intracranial hemorrhage or extensive neurologic damage. So class 2B, level of evidence B, non-randomized. So if patients had a presentitis and they had an embolic stroke, old thought is you want to wait 6 weeks because you don't want to have hemorrhagic conversion, right? But if there's no evidence of intracranial hemorrhage or extensive damage, then it is reasonable to not delay surgery. Hemodynamically stable, you can delay the surgery for up to 4 weeks or greater on patients with infected major ischemic stroke or intracranial hemorrhage, because extending hemorrhage or causing a new brain bleed in this already catastrophic setting is, you want to avoid that. So a neurologic event, there are early operation without delay. If there's no evidence of hemorrhage or extensive damage, or if there's damage or major ischemic stroke or hemorrhage, then you wait 4 weeks, usually about 6 weeks. So I'm trying to have time to move through this stuff. A few of the other updates from ACC 17, I'm just going to go over a couple things. Review of the prosthetic valve anticoagulation. So this is a rhythm for warfarin anticoagulation for mitral valve replacement, a valve replacement with risk factors or with no risk factors. So if you have a mechanical aortic valve with no additional risk factors like left ventricular systolic dysfunction or atrial fibrillation, then your INR goal is, the VA INR goal is 2.5 with long-term aspirin. If you hit that INR goal, bumps up to 3. So that would be systolic dysfunction, AFib, etc. Mitral valve replacement, same thing, mechanical valve. INR goal is 3, along with a baby aspirin daily. Prosthetic valves, so this algorithm is from guideline because it says you can DKA antagonist, the Coumadin, warfarin for 3 months. That post bioprosthetic mitral and aortic valve. The new line, which I have a slide, it increases it to, it's reasonable for 3 to 6 months, and higher class of recommendation. TAVR plus aspirin, but you'll see they've updated that guideline as well. So, patient guidelines also, if there's suspected prosthetic valve thrombosis, if you have evidence of thrombosis or embolism or increased velocities across the valve and you're concerned about thrombosis, you want to check the TEE and then either surgery or fibrinolytics. Slides on the PowerPoint. So 2017 guideline updates regarding the choice of prosthetic valve. When I started working for a surgeon, it was if you were under age 60, you got a mechanical valve. If you're over age 70, you got a bioprosthetic valve. I mean, for the most part. And then 60 to 70, you could make a choice depending on your lifestyle and, how long you thought you were going to be around, or if you did any kind of crazy activities where you wouldn't want to be on anticoagulation, or if you had, AVN or chronic GI bleeds, or, you just had to look at the whole thing. So shared decision-making is always a Class 1 indication in selecting the mechanical versus bioprosthetic valve. But among patients undergoing aortic or mitral valve replacement, the age was expanded from 60 to 70 to 50 to 70 for Class 2, and that's non-randomized trial, but still evidence B. So that's for either a mechanical or bioprosthetic choice. So, we historically would never say have a bioprosthetic tissue valve at age 80 for your valve replacement, because you're going to need another procedure in 12 years. It's only going to be like 62, but maybe you could have a TAVR valve and valve, or, with the evolution of what we're doing, it increases the options for patients. So the ACC-AHA has recognized that, and they have changed their recommendation. There's for the use of vitamin K antagonist for bileaflet or tilting disc valves, mechanical valves. Our goal is 3 for mitral mechanical prosthesis or aortic valve prosthesis plus thromboembolic risk, plus 75 to 100, which we use 81 aspirin for these mechanical valves. There's new consideration for a lower INR target. So if you have an aortic valve replacement patient who's an ONX, it's ONX is the name of the valve, it's a bileaflet mechanical aortic valve, and there's no other thromboembolic risk, you can actually run your INR at 1.5 to 2. They've lowered that only for that specific valve, and it's due to like a carbon-type valve. It's lower incidence of thrombotic events. Dr. Christie has used Onyx. He uses Onyx with his Benzol aortic root replacements. He'll do Onyx valve conduit sometimes, but and that may be just surgeon preference, but he typically uses the St. Jude mechanical prosthesis. But we do sometimes use the Onyx, or there's an ATS mechanical, which is it's a quieter valve, so it's not allowed for patients, but we do have the Onyx here, so you may see it. Or typically, right. And if it's an Onyx valve conduit with, let's say, in the setting of bicuspid aortic valve with a dilated ascending aorta, and we do a Bentall aortic root replacement, so you've got the valve plus that whole ascending aortic conduit. That's got all that conduit and graft. So we would run the INR higher because of that fabric for a period of time, like 3 to 6 months, and then you could drop the INR and go back down to 1.5. This is a 2B recommendation now. So if you just see the mechanical aortic valve and an INR goal of 1.5, don't be worried. It's actually it's a Class 2 indication. And then the prior use for recommendation for VA after bioprosthetic valve replacement was changed to both aortic and mitral for 3 to 6 months after surgery in patients at low risk for bleeding. So I think we see that different culture here. There are some surgeons who just do aspirin, and the patient is at high risk for bleeding. That is completely appropriate. However, they have changed it to a Class 2A. It's non-randomized. It's low in B to use Coumadin for 3 to 6 months for aortic and mitral bioprosthesis. And that's our culture. It came out of favor because there was some discussion, or the risk of bleeding. It's like risk versus benefit, and then there were some papers that did discuss out to 6 months, and that's because the bioprosthetic valve prosthesis involves a pretty significant sewing ring. There's a lot of fabric and suture. So those patients in the early postoperative period, until that has kind of epithelialized, with a little layer over, they are at risk for clot development and thrombus and MS formation. Which VA indicates an INR target of 2.5 could be reasonable for at least 3 months after TAVR in patients at low risk for bleeding, and that's a 2A, so it's not randomized B data. Are we doing Coumadin on any of our patients, or is it just people with AFib? Mm-hmm. Or increase in of thrombotic events, yep. The velocity across the valve, the speed is less, right, because it's less orifice. So it'll be interesting to see.
Well, I think there's like some papers that actually document, you know, clot formation on some of the bioprosthetic leaflets out when they can do it.
And see an increase in the velocity across the valve, you should think possible thrombosis and then institute anticoagulation. They talked about that a lot at ACC. Okay. I'd let and see what they're. Yep. It's all evolving, so next year there probably is going to be another, the 2018 guideline.
Remember the, couple who's got valves and valves.
Mm-hmm.
When they deploy they deployed it too low typically, thank God, not too high, too low, and then they had to go in and put a second bed. And so one patient that's still out there, I believe, and you can actually see both sets of leaflets moving in. So it's like, because it was low, and then they had to put the second one in, and actually just the way they deployed the second valve, both the leaflets working on both valves.
Wow.
Area. That was an interesting case. One I wouldn't want to do that doctor. Heavily at the end of the day. Well, actually, both on that day, both valves were
We're doing more. We're going to keep evolving because we don't know, until we know. We can look back retrospectively and objectively and see what is the best treatment for these patients. So we know when to use anticoagulation for patients with AFib and a CHADS-2 VAS score greater than or equal to 2 in the setting of native aortic valve disease, tricuspid valve disease, or MR. So those patients with AFib, high CHADS VAS, and native valve disease, anticoagulation should be used. That's a class 1 indication. The use of a direct oral anticoagulant, so our newer direct-acting anticoagulants, is reasonable among patients with native aortic valve disease, tricuspid valve disease, or MR, and AFib. So that's the patient who, we just said VKs. Now they're saying direct oral anticoagulant. So I think earlier I said something about the mitral stenosis. This does not include MS, so it's not. Dural anticoagulant in the MS patient with atrial thrombus is not, that's warfarin only, so MS still. But it's 2A for MR, tricuspid, or aortic valve disease. So the mitral stenosis patients, they still want on the VKA. Now it's all okay. You are doing guideline-directed medical therapy. You're on the curve. Yep. Oh, that was native valve. That's native. Yeah, native valve disease. So the direct oral anticoagulants, there is no recommendation at all for.
Medicare maybe start covering?
They should have a high level of evidence.
So the issue, of course, is Medicare covers. Medicare always covers that. They cover it at a
different level or it's so cheap, right? But yeah.
But I have to tell you, like when baby card seems to really work. So if you can, us an opportunity to go ahead and type that great big long letter and say, here's the reason why the patient needs to be on a NOAC versus PIVOT. Just utilize one of those 30-day cards, shoot us a message with this assume, and then we can go ahead and type a letter and get our group try it. If you have 30 days to at least try, and then if we have to, then we can, change it. But that's what I've been doing. I just go on because get them off a little quicker
and try to get them going.
I think they all now have 30-day cards. I think.
Yeah.
For 9 months, they're all put that.
Mhm.
And
Eloquist.
Eloquist, I know, does, they use Eloquist
Mhm.
all the time. Yeah, now they're better. Okay. What's the easiest thing to start? I know it's constantly different. Is there nothing in the house? You know what we should maybe do is, especially for the weekends that we're on call, maybe have a place, in your, farm, you guys refer to it. Maybe come up with a place that we put all those, because I have to say, even sometimes on the weekend when I'm here rounding, you go upstairs, it's all locked, I don't know where I'm going. Or on 4 or 5, just as long as we call. Yeah. Maybe it would be, I'm trying to find a space, and I think that's good, because that's easily accessible for all of us, so that might be better, especially the nurses do on weekends and stuff.
Mhm.
Okay.
Okay.
We'll do that.
I have like a couple slides left. Again, antibiotic prophylaxis before dental procedures is now recommended for patients with transcatheter prosthetic valves and for patients with prosthetic material used in valve repair, which, like Leanne just said, I have been telling my valve repair patients that they ought to have SB prophylaxis. I've seen an increased incidence in endocarditis since we changed the guidelines before, so I'm excited that they are including transcatheter prosthetic valves and then prosthetic valve repair as a Class 2 level of evidence. So, and that was my last slide. So, do you guys have any questions, or there weren't actual antibiotics? So it's amoxicillin 2 grams 30 to 60 minutes prior to, and then if they have penicillin allergy, and that's a good question that you brought up, because we've recently had a patient who had TAVR and had a list of, it's like 20 allergies, and half of them were biotics, and I'm like, what the heck are we going to give this lady for SB prophylaxis? We're going to have to admit her for IV whatever. And so we sent an allergist, and she does not have a fluoroquinolone allergy, nor does she have a penicillin allergy, and so she can safely take her amoxicillin before her dental work every 6 months. So that's good news. So if you do have a patient who has tons of allergies or penicillin allergy, but it was forever ago, we're not sure, we recommend that have them tested by an allergist to determine their true medication allergy. So, thank you, guys.
Thank you.
Thank you. There's some more references, and if you have questions, let us know. I'm a hand talker. This is me. I'm like, okay, so this is the red skull. It's either like this, or it's like this, or there's pop.
And she watched.
It's very technical terminology.